So the first case scenario is the most common indication where we do ILM peeling. That is when we have macular holes, and as you can see over here, the mostly followed technique over here is. Do I? One second. So as you can see over here is what is being done is a macular excess, that is the ILM is being peeled in a fashion similar to a capsular excess, that is in a circular fashion. And this one especially does when you have a comparatively smaller macular holes and you extend as far possible towards the arcades. Another technique where instead of going around, we go across the macula so that you release all the traction that is there, and that is what was being done over here. When you have these larger macular holes, what you can do is do an inverted flap technique, and instead of going all around, you do a peel 180 degrees. And after doing a peel 180 degrees, you begin again on the same end and go towards the other side. The advantage of doing this is that you can have a residual flap that you can leave as a scaffold for the macular hole to close with comparatively more ease. Excuse me. As you can see that after we have a flap remaining, you can go ahead and peel a bit more and extend it towards the arcades. That is what is being done over here. Now, I personally use ILM peeling forceps. I don't have any experience with diamond dusted scrapers. These are slightly more trickier situations when you are when you plan to do peels in patients with vitreomacular tractions. So as you can see, after doing a vitrectomy, what is being done now is shaving on the cortical vitreous around the macula. This is done so that there is a small tuft which remains while you're inducing your PVD. The chances of deroofing become less. So what was being done earlier was PVD induction at the optic nerve head, and now PVD is being induced over the macula. You can see that on the superotemporal side, we have a old branch retinal vein occlusion. That is the reason that the patient developed a vitreomacular traction. And after doing that, you complete the rest of the vitrectomy. Initiating a peel over here is again, you can use any technique. I personally like to go across the macula. It ensures that the chances of de-roofing is comparatively lesser. You have to be very careful while peeling in such situations, and go slow. You don't need to be in a hurry to complete your surgery. Take a bit time and make sure that you don't end up with any complications, iatrogenic complications related to peels. And you can see that it's quite friable, and the peel, okay, it's gone over here. Oh, it's come back. So you're completing the the ILM peel over here. Not very, the cases that you would want to peel all the time, but then patients who are non-responders to intravitreal anti-VEGF injections, especially when the follow-up is going to be tricky, when you have diabetic macular edema, that these are scenarios where you can peel the ILM as well. Patients with proliferative diabetic retinopathy, obviously after you clear out all the membranes and remove all sorts of traction, if it is possible, then in that situation, if the surgeon is comfortable, one can definitely peel the ILM in such situations. As you can see that the retina is comparatively more boggy over here, so one has to be very careful while peeling in such situations. One of my earlier cases when a patient with a macular hole retinal detachment. Now you can see that the retina is quite bullous over here. So in such situations, you can use a PFCL bubble, which helps in providing some amount of counter traction. You can see that the bubble over here is comparatively smaller. So I just put this case and another case over here just to show that the difference. You can use a slightly larger PFCL bubble in such situations, and then this gives you a good amount of counter traction, and you can keep extending the peel as and when you get cleavage planes. As against this, Now, since the last couple of cases, I've stopped using PFCL bubbles in macular hole RDs. Now you can see this particular one. This was a large macular hole, and the good part in this particular case was the retina was not as bullous, and I was able to peel the ILM without the help of a PFCL bubble, and I was also able to leave inverted flap. So that the chances of hole closure are also higher with it. The important thing over here is obviously not to drain fluid from the macular hole itself and create a separate retinotomy site to drain the subretinal fluid. I'm going to skip this one because this is not related to macula. It's just an extension of an ILM peeling elsewhere. Now, there are these certain situations where it's extremely difficult for the instruments to even reach the posterior pole, as this particular one was a highly myopic eye, and a finesse loop, although not the indication for kind of scraping the ILM in such situations, but then it was the only instrument that actually reached the macula. ERMPs, one can also utilize staining in such situations pretty well. It gives you a good contrast. So I'm sorry for the quality of the video over here, but it gives you a good contrast and it stains the ILM. So it's easier to peel the epiretinal membrane in such situations, and you can always stain again with the dye, so that you can make sure that there's no residual epiretinal membrane, and then go ahead and peel the ILM as well. Another not very commonly done indication, but then these particular patients, this particular one, for example, central retinal vein occlusion, a patient had received multiple injections, over 30 injections, classically a non-responder, and the patient was extremely frustrated with the number of injections that he had received. So you can definitely give them the option, or accept their question of if any surgery is possible. So this particular patient also at least did not require further intravitreal injections. Obviously the vision improvement was not as substantial, but then what was
exploring newer skylines after unexpected surprises post-operative. I'm Dr.
Okay, that's not mine. Thank you.